We're going to have President Engineer Mrs. Abby Ebodage. You have the floor. You're muted, I think.
Madam President, you're muted.
You're muted, Madam President.
Yes, good evening, everyone. Good evening, Sister Hope. Thank you so much. Good evening, Dr. Arnold, and all our special guests. We appreciate you for coming and joining us this evening. This is our third NWAG Presents for the year 2025. We welcome you and thank you for joining us. NWAG, as you know, which is the Nigerian Women Association of Georgia, is a nonprofit organization that is based here in Atlanta, Georgia. We turned 25 this year, April 2025. We need a hand for that. 25 years is not a joke. That's a quarter of a century. NWAG has been working tirelessly in the community here in America as well as in Nigeria. We are planning a big banquet this year to celebrate our 25th year anniversary. Please try to join us if you're in the Atlanta area. This will be June 28th, 2025. Please join hands with NWAG to help the less privileged, because this is what we do here in Georgia as well as in Nigeria. We want to thank Dr. Arnold for volunteering his time to talk to us today. We appreciate you for coming, and we appreciate everyone. And I hope you'll be able to learn about HRT and how to keep it in check. Thank you so much. Together we achieve. Now I'm going to read Dr. Arnold's bio. Dr. George Arnold, MD, FRCSC, FSOGC, ABAARM, FAARM. Dr. George Arnold delivered his first baby 40 years ago. And now, 14,000 babies later, he has stepped down from delivering babies and a very busy surgical practice to devote his time to treating hormone changes and impact those changes have on his patients' quality of life. Dr. Arnold served as chief OBGYN at the hospital for 20 years, growing his department into one of the best in Canada. He has been recognized as an expert in OBGYN by the Superior Court of Ontario, the Supreme Court of British Columbia, the Court of Queen's Branch of Alberta, and College of Physicians and Surgeons of Ontario. He was the inaugural chief of the Clinical Innovation and Strategic Ventures at Markham Stouffville Hospital and has served on numerous other committees over the course of his career. He is the author of Feel Your Best, Live Your Best, A Natural Return to Hormone Balance. In addition to the OBGYN training, Dr. Arnold is also board certified in anti-aging, regenerative medicine, and holds a fellowship in anti-aging and regenerative medicine. Dr. Arnold is married to Bimpe and 3 children and 3 grandchildren. So please let's welcome Dr. Arnold.
Okay. There we go. Can everybody hear me okay?
Yes, we can.
Yes.
Wonderful. Okay. Thank you very much, Madam President, for the invitation to join you and your esteemed group today. And as Madam President has already said, you may be wondering why this white guy from Canada got invited to present to this esteemed group. And it's basically because of the love of my life. We have 3 great kids. My wife is Nigerian. God has blessed us with 3 great grandkids, aged 11, 9, and 6 now. And yes, our kids and grandkids all have Nigerian names. And yes, I have visited Nigeria as well. So it's a pleasure to be with you today. I hope you find this time informative, and there'll be something that each of you takes away. So, what is a hormone? Hormones are chemical messengers. They're produced by hormone-producing glands in one part of your body. Then they get into the bloodstream. They travel to a different part of the body where they bind to a specific receptor, which then triggers a response. And some of those processes that hormones are involved in are metabolism, growth, reproduction, mood, sleep. They play key roles throughout both the body of a female and the body of a male. This just depicts that process where a hormone is produced in a hormone-producing cell. It's released into the blood, travels through to a specific cell, and the receptor on that cell binds there and then triggers the response. Now, the interesting thing when it comes to hormones is that every hormone peaks at a certain age and then starts declining. And that whole process is important to understand when we start talking about what these hormones do and some of the changes that they can cause. So there are 3 different estrogens in a woman's body. The most common one, the strong one, is called estradiol. It peaks in your 20s to 30s and then starts declining about age 35 and on. Progesterone similarly peaks 20s to 30s, and then after approximately age 35, declines. Testosterone peaks in your 20s, and the decline begins mid-30s, but sometimes sooner. DHEA is an adrenal hormone. It peaks typically in the 20s to 30s as well, starts declining. And to give you some idea, often by the time you get to your 70s, you'll only be producing about 10% of the amount you were producing in your 20s. And even thyroid hormone. Now, there are 4 different types of thyroid hormone. The 2 that we tend to talk about, free T3. T3 is the active thyroid hormone in our bodies, and T4, they too peak and then they start declining. This, although it's difficult to make out the print here, visually depicts you've got levels, then they start changing. And for a good part of a woman's life, these hormones are produced well below the levels that they were being produced. This is another depiction of estrogen, progesterone, and testosterone. Although some women will be completely symptom-free, have regular periods, one day their periods stop and continue to be symptom-free, those women are the exception. Most will have some symptoms And most women will have those symptoms start well before their periods actually finish. This depicts what happens to thyroid hormone as well, too. It decreases over life. And it's very common for me to see women coming to see me in consultation around the time of menopause who have thyroid issues for things to start changing and them needing a higher dose of medication or a different mix of medication, or for new thyroid symptoms and issues to be showing up around the time of menopause as well. So it's something I screen for with all of my patients. And men face similar changes. So for men, their estradiol also peaks 20s to 30s, gradually declines after age 40. Similar with progesterone. Testosterone peaks a little earlier, age 18 to 25, decreases after age 30 at a rate of about 1% yearly. And similarly, DHEA also peaks early 20s, starts declining, but declines at even a faster rate. And yes, men face the same decline when it comes to their thyroid hormone production. Again, just a visual depiction of a male testosterone peaking 18 to 25 and then gradually decreasing after that. So when it comes to what do these different hormones do, one of the things that I think many people are unaware of is the extent throughout our bodies of where hormone receptors are found. And they're found on almost every cell in our body. So that includes cells in our heart, cells in our lung, cells in our GI tract, cells in our brain, cells in our bone. And everywhere there is a hormone receptor, there's a reason that hormone receptor is there. Same with testosterone. Testosterone receptors are present in just about every cell in a woman's body. So these hormones are not just limited to a certain area. So, just to give you some other examples, where do these act? Hair follicle, brain, spinal cord, nerves, eyes, ears, thyroid gland, cardiovascular tissue, breast tissue, lung tissue, the uterus, the vagina, bladder, GI tract, liver, kidneys, muscle, bone, bone marrow, our joints, even fat tissue. These are some of estrogen's functions in a woman's body. And we're now up to finding about 400 different functions that one of those three estrogens has in your body. So these are just a sampling of those 400. Helps with regulation of the menstrual cycle, reproductive tissue, bone density, skin elasticity, cardiac health, mood, cognition, body temperature, urinary tract lining. The bladder and the vagina are exquisitely sensitive to estrogen. And those changes can start manifesting as symptoms in women that are still having their periods. So, for example, with the bladder, peeing more frequently, getting up at night to go, getting this urgency sensation that you've got to get to the washroom right away, leaking a little bit, even bladder infections. Estrogen plays a key role in how efficiently the bladder empties to clear out bacteria that's normally there, as well as helping the bladder resist infection. Plays a key role in fat distribution, collagen production, immune function, neurotransmitter activity. Estrogen, progesterone, testosterone play key roles in how our brains work and function. Protects against osteoporosis, affects cholesterol levels. I see this all the time in new patients that are coming to see me, especially menopausal. Cholesterol's going up, estrogen's going down. We fix the estrogen, we fix the cholesterol. Hair health, muscle mass, insulin sensitivity, vaginal lubrication, breast tissue development. And similarly, progesterone, tremendous different effects. So, yes, plays a key role in pregnancy, balances estrogen, key for sleep, both quality and quantity of sleep through its impact on our brain neurotransmitters. It has a calming effect on the nervous system, thyroid function, bone, inflammation. Progesterone acts as a natural diuretic, breast tissue, mood stability, metabolism. DHEA acts as the building block for our own body's production of hormone, supports stress. The adrenal gland, which is where DHEA is produced, is our body's stress hormone response center, helps us cope with stress. But if you're under chronic stress or repeated acute stress, the adrenal gland's ability to keep up can diminish. And then we can see you're starting to get sick more frequently. It's taking longer to get over an illness, new allergies coming up, allergies worsening, just as your body starts breaking down a little bit, isn't able to cope. DHEA plays, therefore, a key role in immune system function. Helps with skin hydration, elasticity, muscle health, sex drive, sex health, fat metabolism. You can also see there's a lot of overlap between the functions of the different hormones. And then I'm going to spend just a little bit of time going through testosterone because there's a very real under appreciation of the importance of testosterone in a woman's body. I hear it all the time from my patients. Doc, I thought testosterone was the male hormone. It's like, well, it is one of a number of male hormones, but it's also a very important and key female hormone. Helps with libido, sex drive, helps with muscle health, helps with bone health, helps with brain function and memory, impacts energy levels, affects confidence, affects motivation, helps regulate mood, impacts fat, metabolism, and distribution. It contributes to red blood cell production, important in skin health, well-being, and confidence. And as you can see from this slide, testosterone gradually decreases over a woman's lifespan. So once you're hitting the menopausal years, average age of menopause in North America is 51. So basically, once you're getting 55 and up, you'll see the testosterone level comes in almost about a third of where it had been when you were younger. And this, for most women, does have an impact. So what happens when testosterone declines? Loss of energy, fatigue, impact, brain fog, mental clarity, focus, muscle health, exercise tolerance, mood, anxiety, depression, irritability, key hormone when it comes to sleep disruption. Also, as we'll see in a few minutes, probably plays a much underappreciated role with things like chronic pain, fibromyalgia, and then, of course, decreased sex drive and sex desire disorders. So, a couple of things to appreciate here. These symptoms can occur at any age. So I will have women in their 20s coming to me with symptoms related to hormone change. I have women in their 90s coming to me with symptoms of hormone change. So there isn't just one age at which, if you get there, it's like, oh, I'm home free, I'm fine. Nope. So both young and old, it's keeping an open mind as a healthcare provider. So you don't shut out an investigation or a consideration just based solely on age. And the other thing here, probably because of a lack of knowledge about hormones and hormone change, as well as sometimes a stigma that's attached to that, although more and more women are seeking investigation and help. This study from 20 years ago showed that only 10% of women with symptoms seek medical advice for these types of symptoms. And we can do something about this in a very healthy and safe way. So it's not, well, you're going to seek and there's nothing that can be done. There are things that can be done. Diagnosis is challenging because right now with testosterone, there are no medically defined lows and highs for optimal symptom control. The ranges that are attached to these levels that you get from the lab for many of the hormones are just based solely on the people the lab has tested over time. They're not based on specific studies showing optimal low, optimal high. I use numbers to typically be able to say, yep, your levels are low, but it's the symptoms that the woman is experiencing that also plays a key role in treatment. So if we add testosterone back, what can it do? Helps with muscle health, helps with energy, helps with brain function, helps with mood, improves cholesterol as well. It's heart protective, it's bone protective, it's breast protective, helps with pain, helps with sex drive. So many benefits. Fascinating work that's being done now. Testosterone in Alzheimer's disease. If you look at the impact estrogen and testosterone have in our brain function, They regulate key processes that are implicated in Alzheimer's development, specifically the accumulation of the beta amyloid plaque that goes along with Alzheimer's. So opening up tremendous treatment and preventative strategies. What about the other impacts? So testosterone low levels are associated with not only sexual dysfunction, but different mental disorders. So just being aware of that can impact treatment. I see this regularly. The psychiatric group in my hospital picked up a long time ago that many women around the menopausal change would also, if they were on psychiatric medication, all of a sudden things are thrown off and they're adjusting medications, adding new ones in, bumping the dose up, but they're having trouble getting back to those women being as good as they were before their levels drop right off. All has to do with hormones. We get their hormones stabilized, it can completely turn around the symptoms that they were experiencing. We see this with testosterone and depression. The hippocampus and the amygdala are two areas, critical regions in our brain that play a role with mood disorders. They are rich in androgen receptors. So it would stand to reason that low testosterone would impact these mood disorders. So the pharmaceutical industry has been focused on medications that impact serotonin, and we have a number of very good ones. But if we back up, it's like, what's causing all of this? They've sort of missed that androgen receptors impacted by testosterone and to some degree estrogen as well could play key roles in many of these treatments that are used for these mood disorders. What about the cardiac system? Testosterone, what are the blood vessels? Blood vessels are tubes of muscle that constrict or dilate and react. Testosterone plays a key role in that whole process. I had a patient probably 5 years ago. She was on hormone replacement therapy. She had a heart attack. And her cardiologist told her, you've got to stop your testosterone. And she goes, really? And so she called me, do I really have to stop, doc? And I said, no, that's not what the studies show. So I called her cardiologist up and I said, what's going on? You'd recommend she stop the testosterone. I said, can you provide the studies on which you're making that recommendation? And he goes, well, not really, but that's what our society recommends. I said, well, good for your society. Give me the data, because I've got a couple of good studies that I can send to you that shows testosterone is heart protective. It's not going to impact her in any negative way going forward. So we reached an agreement where he said, okay, I will look after her heart. You look after her hormones. She's carrying on with her hormones. She has done absolutely great. What about bone health? Testosterone plays a key role, and we'll get to this in a little bit. Two issues with bone. The bone strength, which is where the minerals go, but that's not the issue with bone fractures and osteoporosis. That's a bone matrix or bone resilience issue. And that's why calcium, vitamin D, the other minerals, they don't impact the bone matrix. Hormones do. That's why hormones make such a difference to the women that are using them with preventing the hip fractures that come up later in life. What about breast tissue? Testosterone, very active in breast. It decreases tissue proliferation. So, what about testosterone in breast cancer? Well, it's actually been shown to be breast protective in both premenopausal and postmenopausal patients. We'll get to estrogen does not cause breast cancer in a moment. Have lots of studies to quickly go through with you. This is just one study looking at either testosterone and a combination of testosterone with estrogen. 10 years of data looked at. And what they found was they were comparing this to the Women's Health Initiative in the placebo arm. So these women weren't on hormone. The incidence of invasive breast cancer, 330 per 100,000 women. Similar to the never users of hormone in another large study, the Million Women study, 312 per 100,000. People on testosterone or a combination of testosterone and estrogen, 144 cases. So less than half the ratio of the other studies. So is this 100% protective? No, I wish it were, but it's not going to increase your risk. And as this study showed, it will actually decrease your risk. What about reference ranges? We touched on this a little bit. So there is no medically validated reference range. Most of the reference ranges are for women who aren't on replacement therapy. So in Canada, our reference ranges are different from the States. But for a woman above age 50, it's 0 to 35. Well, clearly, 0 is not a great place for your testosterone level to be. Okay, so what about testosterone in males? Very similar types of effects there. And similarly, with low testosterone, very similar effects: decreased sex drive, erectile dysfunction, muscle health changes, impact, mood, irritability, brain fog, memory, sleep issues. So let's spend a few minutes just going through what I hear all the time. And for the doctors in the group, you probably hear it as well. But doc, I thought estrogen causes breast cancer. And it's like, no, it doesn't. The belief that estrogen causes breast cancer seems to be relatively logical, widely accepted, but completely wrong. So I'm just going to go through some things. So if estrogen causes breast cancer, when you become menopausal and your estrogen level drops down to a fraction of what you were producing before, breast cancer rate should decline. They don't. They do exactly the opposite. For every decade of life, 50 to 60, 60 to 70, 70 to 80, they actually increase. High-dose estrogen used to be a treatment for metastatic breast cancer. You would expect then, if estrogen were causative, your lifetime exposure would contribute to your breast cancer risk. It doesn't. What about pregnancy? Estrogen levels are 10 times higher during pregnancy. But pregnancy doesn't increase your breast cancer risk. Early and multiple pregnancies actually reduce your lifetime risk. Pregnancy less than age 20 reduces your risk. And women with a genetic mutation that increases their risk of ovarian cancer and breast cancer actually show no increased risk associated with pregnancy. Women diagnosed with breast cancer during pregnancy have basically the same prognosis with non-pregnant women. Pregnancy after breast cancer treatment, no negative effect on prognosis. And terminating a pregnancy doesn't change the outcome from breast cancer. Well, doc, my breast cancer, I was told it's estrogen receptor and progesterone receptor positive. Estrogen receptors and progesterone receptors are found on normal breast cells. Fascinating. What are the cells that increase significantly in a breast cancer? Well, it turns out most of them are estrogen receptor negative and progesterone receptor negative. There are different cell lines, and the understanding of those different cell lines never gets communicated properly. So let's look at some of the large studies done to help us understand the connection between estrogen and breast cancer. 86, no increased breast cancer in long-term Premarin users. Premarin still remains a very common oral estrogen to take. 88, no link. 91, no association. 91, 15 years of Premarin use, no risk. 92, a 22-year study. HRT users, 0 breast cancer, 11.5% in the control group. 95, a reduced breast cancer risk. The Nurse Health Study, no increased risk. 97, no increased risk, even with a family history. Another common thing, oh, doc, my family doc, I went to see them about using hormones, and they say, oh, no, you can't because of your family history. No science supporting that. Further studies, no risk, even in women who are genetically predisposed to a higher risk of breast cancer. In fact, study from 2008 actually decreased risk in some of those people. Consensus conference from 87, no increased risk. An editorial endorsed HRT for all postmenopausal women. Consistently, no increased risk across multiple studies. So, what about the studies that do show a connection? So, this was one of the first ones. And this was published in the New England Journal of Medicine in 1989. And the press sort of part of this was that HRT caused a 440% increase in users. Fascinating study when you looked at it. So this came from Sweden, where they have access to people's medical records. They were looking at 23,000 women, but they realized that's going to take a lot of time. So they picked one of every 30 women just looked at that small group. So it was a group that came to 638 women rather than the 23,000. And in that group of 638 women, they were expecting 2.2 breast cancers. They found 10, and that was the 440% increase. However, every study, what it needs to tell us is this result just based on chance alone, or is this not just chance alone? And that very simply is what we call statistical significance. So if, as was the case here, this result was not statistically significant, what that means is that this small group of women, we could not say with certainty that that was not anything other than chance alone. But as we'll see, the media likes to take a relative risk, which is our percentage. That sells. If you just said, well, this study was statistically insignificant, most people would completely overlook that. And that's what's happened with later studies as well. This was another one, the collaborative group in 97. Sometimes what'll happen, you'll get a result that the group doesn't want, and then you'll go back to manipulate your data to see, can we find a small group somewhere that is going to tell us what we really want to see from this study? That's something called data mining. It's alive and well, but that can completely skew a result. And that's exactly what happened as well with the Women's Health Initiative trial, 2002. The estrogen-only group had no increased risk. The combined group had a small increased risk, but again, it was not statistically significant. But by the time that study was actually published, the media had already gotten a hold of it. Fascinating story that could take up our whole time together, just going through how results were released without the group that was overseeing those results. And just a fascinating story. Long and short, it caused so many women to stop using hormones with no science behind it. And really, this is the largest randomized trial, and they failed to prove the link between estrogen and breast cancer. But 23 years later, if you ask people, oh, there was that study, I don't remember what it was called, but it was a study that found that estrogen caused breast cancer. And that's why, my mom stopped using it. And it's like, no. Anyway, so very simply, the Women's Health Initiative trial had a terrible control group. 70% of the women were overweight, 50% considered obese, medium age 63, only 10% were age 50 to 54, 50% were current or past smokers, 35% had high blood pressure, all risk factors for breast cancer. Well, you would think if you want to see, does estrogen cause breast cancer, you're going to control for all of the other things that do, so they're not going to skew or screw up your data. So what are the real takeaways? There's no link. They then put forward this withdrawal hypothesis that women who went off HRT when the study was halted were less likely to develop breast cancer. Didn't hold up. And they also showed that estrogen alone in women who had had a hysterectomy was associated with a decreased risk. So again, nothing. This is another one. So this is why this concept of significance is so important. And the takeaway is it needs to be statistically significant, which means the study has shown this is not just due to chance alone. We then have media significance, we have medical significance, which can be based on media significance. And now in our current day, we have online significance, which can be driven by influencers with absolutely zero medical background, zero understanding of how studies are done. So takeaway, just be careful where you're getting your information from. I'll just zip through this, but here are, oops, looks like 26 studies of breast cancer survivors
Dr.
using,
Arnold,
yes.
go ahead and share your screen again, sir.
Oh, thank you. My apology. Okay. So, sorry about this, everybody.
That's okay.
I guess you all needed a bit of a break.
No,
Okay, there we go. Okay, so let's get this back here.
Wonderful, got it.
And my apologies, everybody. So 26 studies of breast cancer survivors who were put on hormone replacement therapy. And the long and short of this, 23 of the 26 studies showed no difference or a reduced likelihood of recurrence. And of the 3 that did, again, not statistically significant. What about testosterone? Because I'll hear this from my male patients as well. Well, testosterone does this, or it causes prostate cancer. No, no, no. So most common benign condition in males, 80 to 85% of males will eventually develop an enlargement of the prostate that's benign. Testosterone's not the driver. And it doesn't increase prostate size. It can actually improve symptoms in guys that are on testosterone replacement therapy that have symptoms of prostatic hypertrophy. And the whole testosterone prostate cancer link, no, that's been pretty much put to bed as well now too. No clear evidence that normal testosterone levels cause prostate cancer. Low testosterone levels are associated with more aggressive forms of prostate cancer. There is no increased risk of developing prostate cancer on testosterone replacement therapy. So that's been put to bed. So why all the focus just on estrogen? When we started, I took you through there are 3 different types of estrogen. There's progesterone, testosterone, DHEA, all doing different things. And that's a good question. But still, estradiol remains the prime focus of replacement for Western medicine. When I started into my GYN practice, which was in the early 90s, many of the women that were coming to see me were on hormones and either having side effects from those hormones or the hormones they were on were not taking care of all of their symptoms. That started me on this journey of looking at alternatives, looking, well, what about other hormones? And truly, a more comprehensive approach recognizes the importance of balancing multiple hormones, not just one estrogen, to address the full range of symptoms and promote overall well-being during perimenopause and menopause. And that's certainly what I have found and continue to see. What about heart disease? Well, actually, heart disease is a whole lot more common than breast cancer. And 1 in 5 female deaths, this is data from 4 years ago, was caused by heart disease. You know, less than, or probably coming in about a quarter of that was breast cancer. The strides that have been put forward and made in the diagnosis and treatment of breast cancer are fantastic. 5-year survival now, 90% if it's localized when it's found, 98% 5-year survival. And yet the fear and the anxiety that breast cancer still creates is huge. More women over 40 die from heart disease than breast cancer. In fact, breast cancer survivors are more likely to die from heart disease than they are from their breast cancer. Hormones help with that. Well, what about using something else? Well, we've tried a number of other things. Interestingly, statins are less effective in women than men. Yep, there's a difference between the sexes. In women without heart disease, statins do nothing to reduce mortality or non-fatal heart attacks. In women with heart disease, statins can reduce the risk, but they increase the risk of diabetes. So we're fixing one thing, causing another. Hormones help with both. Hormones are heart protective, but if you stop your HRT, that protection for heart is lost in 1 year. For bones, it's lost in 6 years. So you need to keep going with these. And as we'll see, it's safe to do that. What about osteoporosis? This just lists some of the demographics that predispose to it. Interestingly, again, 70% of hip fractures occur in women. They happened 5 to 10 years earlier in women than men. And if you go through menopause earlier than age 51, you're not on hormones, your fractures happen even sooner. So this slide focused on a little before the difference between bone density and bone resilience. Think of resilience. If you take a bone and you put it in a vise and you try to bend it, it's the time at which that bending actually snaps the bone. And a young bone will take a tremendous amount of stress before it snaps. An old bone, not so much. That's resilience, and that's due to what's inside the bone, what's called the bone matrix or the osteoid. Hormones are one of the few things that impact that. Your calcium, your vitamin D, that's impacting the strength on the outside, but it's not impacting what's inside and the resilience. What happens with age, the collagen fibers in that matrix start thinning out and become much more fragile. And hormones play a key role in collagen formation. So all of them do, estrogen, progesterone, and testosterone. Some studies would suggest testosterone's the most important of the three hormones when it comes to new bone formation and maintaining that osteoid or the bone matrix. So we had touched on this a little before, that unfortunately hormones aren't like antibiotics. You take them for 7 days and they fix everything going forward. They need to be continued to maintain benefit and to keep that benefit going forward. These were some interesting stats that I came across. So if you're a female age 60 or older and you fall and you break your hip, the risk of death within the next 12 months is 20 to 25%. If you are diagnosed with a breast cancer, the risk of death within the next year is much less than 5%. And what are your 5-year survival rates looking at? Well, you'll likely, if you are diagnosed with breast cancer, 90% chance of you being alive in 5 years. Hip fracture, 60 to 70%. Heart attack, 52%. What can help lower the risk of hip fracture, the risk of heart attack, have either no impact on you developing breast cancer or a lower risk of that? Hormones can. So estrogen does not cause breast cancer. Estrogen reduces cardiac disease and hip fractures. One of the things that I've learned in my practice, Western medicine tends to focus on symptoms. And like you go to your family doc, oh, we're just dealing with one symptom today. I've got 5. Oh, sorry, you're going to have to make another appointment and come back. And then you have a treatment for every symptom you have. Well, what if all of your symptoms are being caused by the same thing? And it's a different way of thinking. It's like, what is the root cause of all of this? You saw all the different things hormones can do, symptoms they can control. In a few slides, I'll just give you an idea of the number of symptoms I canvass people on when they come to see me. We're looking for the root cause, because if you can find the root cause and treat that, you'll have far better results. And I see this all the time. The go-to for a lot of family docs for women in their 40s when they start having symptoms, let's stick you on an antidepressant. That's the cure for everything. Well, it may help with mood, it may not. We see increased weight because it increases appetite, it slows metabolism, it shifts hormones. So often it can end up causing more things to happen than were there in the first place. It can decrease sex drive, cause vaginal dryness. It increases a binder called sex hormone binding globulin that takes free testosterone out of the blood, so it actually lowers that. So what can happen? It can end up making symptoms worse. And then you go back to your family doc and, oh, we just need to bump the dose up even more. And you get into this vicious negative feedback loop that hasn't fixed the problem in the first place. It's just made it worse. And again, we're picking off one symptom instead of looking root cause. So what are the different hormone phases? Perimenopause just refers to a time of change. And for many women, that'll start in their 30s, some in their 40s, some late 20s. New symptoms come up over time, the symptoms worsen. Menopause, Symptoms, no period. Andropause, the name given to male hormone change and the symptoms that can come up. And it's not just the symptoms, it's the impact those symptoms have on your quality of life. So the whole goal is to get you back feeling yourself again. And these are just some of the symptoms I have women rate prior to seeing me. So I've got a very good idea. My questionnaire is actually 7 pages long. It takes anywhere from 45 minutes to an hour to fill out before you see me, but gives me an excellent idea of what's going on. Some of these, very common: hot flashes, night sweats, heart palpitations. Turns out the heart is very sensitive to estrogen. I don't know how many patients I see on an annual basis. Oh, doc, my heart, it just like started skipping beats and then I started getting pain. I thought I was having a heart attack. I went to the emergency room. I had an echo done. I had an ECG done. They did all of my labs. And, thank the Lord, my heart is fine. It's like, great, what caused your symptoms? Because it's like, doc, 6 weeks later, exactly the same thing happened. I went back and they did all of the tests again. And I followed up. I was referred to a cardiologist and he said, your heart's fine. It's like, it's your hormones. We get the estrogen up, it fixes all of this. Weight gain, huge issue at this point in time. Vaginal dryness, we've sort of talked about, the irritability, the burned out sensation, often adrenal, foggy thinking, huge low progesterone symptom, sleep, progesterone, memory, estrogen, this tired but wired feeling that a lot of people will start experiencing, adrenal, the muscle aches, low testosterone. We've touched on elevated cholesterol, blood pressures, some of these other things. Fibroids and endometriosis are an imbalance, long time imbalance between where your estrogen is, where your progesterone is, something we call estrogen dominance. And the same thing in guys. Guys get hot flashes, guys get night sweats. Many of the same symptoms. They'll get the brain fog, they'll get the mood changes. These are, for many guys, just natural changes reflecting lower hormones. So it's important when you're looking for somebody to help you that these 5 pillars are there. So you deserve to be listened to. I don't know how many people end up in my office, and if doctors had listened to them, they would have had their problems solved years ago. I had a 17-year-old in my office 3 weeks ago that started to develop a seizure prior to her period, when her period started. I don't know how many specialists she's seen, how many different anti-seizure medications she's been tried on. All of these docs needed to do was listen to her and her mom. Between day 7 and 14, every cycle, that's when her seizure happened. Is there a connection? Absolutely. A rare disorder where too much estrogen, and it peaks in the middle of the cycle, is stimulatory and can actually trigger seizures very rarely. As we had shown before, progesterone is calming. We evened out her hormone production, added some natural progesterone in. 5 months, no seizure. It's like all you needed to do was listen to this woman. And I could probably fill a whole book with people that it's like, I don't think I'm anything special, but God gave me 2 ears. I use them, and it's helped me tremendously. You deserve to be acknowledged. So many docs, I hear the story. It's like, I told my doc about this. They just shot me down. It's like, oh, that's just normal. Oh, what are you complaining about? Just live with it. Oh, you're still having your period, so can't be hormones. It's like, no, 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 no. You deserve facts, not fear. And this is another thing. It's like, present the information. Don't just share your bias as a physician. Oh, you can't go on that. That's going to cause breast cancer. Oh, you can't do that because of, oh, like, what are you thinking? It's like, really? Show me the facts. You deserve options, and you deserve to be involved in the decision-making process regarding your health care. So just a few insights to leave you with, and thank you for your attention. I'm sure I've run over a lot of stuff to try and get through to you, but treat the cause, not the symptoms. Treat your patient. Don't just treat a number on a piece of paper. I see that all the time as well. Symptoms from hormone change can vary from person to person. These symptoms can start early. Different symptoms have different thresholds. If you're still having periods, you can still get symptoms. Treatment can start at any time. We talked about vaginal dryness. Recurrent bladder infections can be a sign of decreasing estrogen, even if you're still having your periods. There is no time duration for hormone therapy, after which it has to stop. This is another thing I still see. Oh, you've been on your hormones 5 years, you've got to stop. That number was pulled out of thin air. There is no science behind it. In fact, the North American Menopause Society, something called NAMS, put out a white paper in 2017 recognizing that regardless of age, there is benefit to hormones and taking away the 5-year duration, also taking away the 65-year-old time cutoff. I had a 91-year-old that I saw a couple of months ago. New doc forced her off her hormones, wouldn't produce her, wouldn't prescribe them. Her energy went down. She couldn't concentrate. She wasn't able to keep up the way she had before. Complete nonsense. Started her back on, got her back up to her full self again. And it's like, I see this and it's needless. Don't forget the men in your life. I got into treating men through the women that I saw. It's like, okay, doc, you've got to fix my partner. He can't keep up with me anymore. So I've been treating men for quite a while now. And finally, I tell my patients this all the time. My role is to give you the information you need to decide what's best for you, not to tell you what to do. As long as you have the information, I will respect whatever decision you make. And that could be not now, it could be yes, or it could be no. And that's fine. You have the information. You decide. I'm here to support you. Thank you.
Wow. Thank you, Dr. Arnold. Wow.
Yep, that was chock full of information. Very informative.
Very, very informative.
Thank you.
I'm just sitting here blown away with my mouth open. The ailments, the symptoms that are all tied to your hormones, like the hormones are a huge driver. Like everything, almost everything that you can think of is tied to your hormones. And people go through this, treating that. It's that part where you're just treating symptoms for this, and it's all tied to the one motherload the hormones.
You got it.
All right.
Absolutely right.
We're going to take
Absolutely
questions
right.
now. We'll start with
Sure.
the questions in the chat. Dr. Oruchi Opara, can you help us with that, please?
Oh, sure, yes. Thank you once again, Dr. Arnold. We do
Thank
have some
you.
questions. I mean, you gave
Of
us,
course.
you empowered us with a whole bunch of information, and with that's going to come a bunch of questions. We do have some
Good.
questions in the chat. For those who are not able to put in the chat and want to be able to address them to you directly, feel free to raise your hand and I will call upon you. But I'm going to start off from the chat. And the first question we have comes from Miss Angela Madubam. And her question is, can one avoid medication to treat hormonal issues with just nutrition?
I wish you could, but simply no. There aren't any foods ultimately that are going to be reliable and consistent source for estrogen, progesterone, testosterone, DHEA. So at least not that I'm aware of or that I have seen. So no, the only way of treating hormone deficiencies or decline is by adding hormone back. And when we add it back, my colleagues approach her in the same space as I am. We start low and we go slow. We see how you respond. A little bit of hormone can go a long way. The other thing, what we're doing over time, if your level had been here, it's dropped to here. We're looking at restoring this little bit you're missing. The hormone, once it gets into you, doesn't tell your ovaries, oh, you don't need to make hormone anymore. So it doesn't take you from here, push you down to here, so then we need to give you even more. So that's not how this whole approach works. But your initial question, can I do this with food? I wish you could, but no, you can't.
Thank you very much for that answer. Our next question comes from Dr. Yeti Eziani, and her question is, are there any issues with starting hormone replacement therapy over 10 years after menopause?
I have not found that, no. So, and a lot of it has to do also with age and the situation in which it comes up. So I can give you a few examples. I had a 61-year-old in my office recently. Menopause started 10 years ago. Her symptoms of anything have gotten worse. He just kept hoping, oh, it's going to get better. It can't last forever. It's like at some point, this is going to improve. And it just hasn't. She is fine starting on hormones. I'll see people say in their mid to late 60s, went through menopause, early 50s, no issues at all. They end up with an ovarian cyst or some reason for needing a hysterectomy. It's like, oh, your ovaries aren't needed anymore. We'll just take those out at the same time. They come out and after their surgery, hot flashes, night sweats, sleep disruption, moods. It's like all of the things that they had missed like 15, 16, 17 years earlier, they're now experiencing. And what you'll see in the medical literature where they followed women in their 60s, 70s, and 80s, many women have a tiny bit of hormone that's still being produced that is enough to take care of their symptoms until it's not there. And then all of a sudden, it's like this. I'll definitely treat them. Sometimes I had somebody in recently, hadn't had her ovaries out, but she had been 16 years, no symptoms. that tiny little bit of change. And it's like, I feel like I should have felt 15, 16 years ago. I will treat them.
Take the
So,
Florida 826 East exit toward Beaches.
Can you please be muted if you're not talking, please? Thank you.
good question. Anything else?
Oh,
Dr.
there are
Parra.
more. Yes, there are more questions. Sorry, that was my navigation.
No
Oh,
problem.
Okay, yes. So the next one comment or question comes from Miss Sonia Graham, and she would like to receive a copy of the list of women's symptoms that you put up there. If not, sure, just your whole presentation. So are you willing to allow us to have your presentation distributed?
Absolutely. Absolutely. No problem.
And I know, I guess to add on to that question, are you open to having attendees call you with their questions after this presentation?
Absolutely.
Okay, so we'll share that.
Absolutely.
We'll
Sure.
share your contact
Please.
information in the chat then.
okay.
Yep,
I'll go
thank
ahead
you.
and do that, Dr. Parra.
For half a mile.
Okay. All right, and I actually had a question. I know you mentioned that estrogen is cardioprotective, but how do you reconcile that with the consensus out there that women who are on birth control after the age of 35 should avoid, I guess, birth control to reduce the risk of experiencing a blood clot, stroke? Can you shed any light on that?
Sure. So actually, I'm not aware of the specific demographic group that, given everything else is fine about age 35, that should stop. I am aware of that group, including other specifics like smoking, other risk factors that would potentially increase that risk. But if they're healthy non-smokers, there's no reason for a woman age 35 to stop the pill. There are a number of studies showing that carrying it on for a 4 to 5 year period, anytime after age 35, actually reduces your risk of changes to the lining of the uterus, endometrial hyperplasia, and endometrial cancer, and actually reduces your risk of ovarian cancer. Now, there's a big difference between the amount of estrogen that's in a birth control pill and what we replace. And the other key difference is how that estrogen is given. Estrogen given orally is processed through the liver, where it has the impact on the clotting cascade. If we take that same estrogen, put it in a patch, a cream, a gel, deliver it what we call transdermally right through the skin, gets into the blood, bypasses the liver, zero impact as far as the clotting cascade. So who it is, how it's given, can impact those things tremendously.
Oh, thank you very much for that answer.
Sure.
We have another comment just attesting to the awesomeness of this information that you shared with us. So thank you once again. And then we have from Dr. Winifred Mweke. She asked to see the chart or graph that shows the decline in estrogen or testosterone, but I know you said you're open to having your presentation shared.
Absolutely.
So I didn't know, Dr. Mweke, was this something you wanted to, you had a question about that you wanted to address live, or you just wanted to see the graph? Because if you want to see the graph, I think that, you know, we will make the presentation available.
Okay. Yeah, what I wanted to look at again is that the last age group that you showed on that graph at the bottom, it seems like the level of, I don't know whether it's specific hormone or hormones in general, where you showed the decline with age. But the last age group, it seems like it was turning up again. It was increasing.
You are amazing.
Yes, after 65, I saw that too.
You are still Like, that is a very good pickup. And I'd seen the same thing, and it's like, this doesn't make any sense to me. So I hadn't had a chance, as one of the few sort of depictions of testosterone overall. But I hear you. I agree with you. That doesn't make any sense. It's like, oh, maybe this group actually started on testosterone, so it's coming up a little. So excellent pickup. I agree with you. That doesn't make sense. Hadn't had a chance to look in for an explanation as to why it went up that little bit, but excellent pickup.
Well, we leave it for Dr. Wicked to be able to make sure that all our T's and I's are dotted in our organization. So
Absolutely.
Okay. The other question, the other question I have is, okay, if this much, the hormones play this much role in health, has this gotten into medical education? How come it hasn't? How come many doctors don't know that?
Another excellent question. I know in my local university, my OB/GYN residents get about 2 weeks out of 5 years on menopause training. It's just not got the allure or whatever you want to call it of surgery. I mean, it's still, how much time can I spend in the OR? How much can I learn about these different techniques? Even more so than obstetrics. A huge shortcoming and a huge failure as far as the importance of hormones, understanding how they work. I would say 99% of my knowledge didn't come from my traditional training. It came from me sourcing and going after this information, me paying for the additional training and education that I have. And that's where I found tremendous help. And so, yes, it's a huge failure as far as the current, even the current educational system. For family docs, same thing. Like, there's almost zero training in this. So it's an area that needs a lot of attention and could have huge benefits, but we're not there.
Okay.
Yep.
Thank you.
okay. Next question also comes from Dr. Yeti Eziani, and she would like to know what's the best form to start hormone replacement therapy? Is it orally, using patches? We know we've got rings. What's your take on that?
Sure. So I'd probably divide that into traditional and alternative. So on the traditional side of things, I would look at using something transdermal. So either a gel or a patch. Downside, it's just estradiol you're using. You don't have the advantage of being able to add the weak estrogen estriol in, but it does a decent job. Progesterone, I go with micronized oral progesterone, Prometrium, or one of the generics, 100 milligram dose. What I find for many of my patients, it's either too strong and they get side effects from it, or it's not strong enough. Certainly in Canada, there is no commercially available testosterone for women. There's no commercially available DHEA in Canada. In the US, you can buy DHEA over the counter. Alternatively, I use a lot of compounded medications. I believe in their safety, their efficacy. I've been using them for close to 25 years with amazing results. So you can compound testosterone, you can compound estradiol and estriol into a cream. I'll use transdermal progesterone for perimenopause changes, find that works really well. If sleep is an issue, I'll use oral compounded progesterone at a very low dose. That seems to work great. The closer you get to menopause, the higher doses you need. And then once menopausal, some women will need much higher doses of progesterone. So it depends what space you're in, what you're using, but there are a lot of options there for you. I try and avoid oral estrogen just because of its inflammatory effects and the effects on the clotting cascade. There are no no's in my practice. So I have some women who everything else hasn't worked. Oral estrogen is the only thing that has to control their particular symptoms. So again, it's starting with what you're comfortable with, what typically works. When it doesn't, then you start looking, why? Why isn't this working? So hopefully that helps.
Awesome. Thank you so much, Dr. Arnold. I think you answered the next question, which are whether there are any known side effects from your treatments. You mentioned a couple of things.
Yeah.
Are there any others we should be aware of?
So with hormones, too little can cause symptoms, too much can cause symptoms as well, too. So too much progesterone, breast and nipple sensitivity and discomfort are probably the most common symptoms, can make you feel a little sluggish the next day. Sometimes will give you either some menstrual cramping or late cramping, those typically too much. Estrogen, sometimes same deal. It can sometimes give breast and nipple sensitivity, although less commonly than progesterone. Too much estrogen menopausally often will cause a little bit of breakthrough bleeding. In younger women can make a huge difference with menstrual migraines, just adding a tiny little bit in. Even in women menopausally, where migraine headaches have become more frequent, estrogen can make a huge difference there. Testosterone, oily skin, breakout, chin and back, most common. Likelihood of that less than 1 in 20. Being more aggressive or just angry, the likelihood of that happens. It's extremely rare, though, much less than 1%, all entirely reversible. So there's nothing that these hormones can cause to happen that then persists even once you've stopped using them. DHEA can sometimes just give some funny dreams, nightmares. Likelihood of that less than 2%. Can cause hair thinning, hair loss, probably about 3-4% of the time. So these can all happen, but they're not common to see. And again, because we're starting at a very low dose, we follow symptom response, we follow levels as well too, and then gradually increase as needed. So that particular approach has served me and my patients very, very well.
Wonderful. Thank you so much, Dr. Arnold. Do we have any more questions? And please feel free to unmute yourselves if you wish to, and just go ahead and ask. The floor is open. Anyone? I don't think
Okay.
I see any more
Final.
questions in the chat.
Oh,
Yes, ma'am.
so the final question is this.
Yes.
Actually, so Dr. Arnold, bottom line is everybody needs hormone replacement treatment. Is
Yes.
that it?
Yes, I would agree with that. From what I've seen, yes.
Okay.
So Dr. Nweke, you see the reason for the topic?
Well, yeah, because I was asking, I was saying that kind of assumes everybody needs it rather than saying who needs what. But you're saying from what you said, everybody needs some.
From what I can see, yes. I would take us back to that consensus statement from, that was what, 89 or 92, where all of the studies up to that, looking at the benefits that were coming. And I think we're able to tailor and customize hormone treatments, fine-tune them much better now than we were 30 years ago. We have far better tools and ways of doing that to make things even better. So I use hormones. My wife uses hormones. You know, when it comes time, my oldest daughter is getting to that time in life where there's some changes that are starting. So I'm a big proponent of that. Yes.
Okay.
Okay.
Okay, so we have Dr. Arnold's contact telephone number in the chat. If we do not have any other questions, I guess we'll move on to the next item on our agenda, and I'll pass it on to the Vice President.
Thank you, thank you, thank you. Let me see here. A moment, please. All right. Thank you, everybody. Thank you, Dr. Arnold. Wow. Amazing, amazing. I would like to extend our heartfelt gratitude to everyone who has attended this NWAG Presents Do I Need Hormones? Featuring our esteemed Dr. Arnold. Your presence and engagement made the event a resounding success, and we're thrilled to have the opportunity to share valuable insights on hormonal health with you. We're grateful for the support of our members, our volunteers, and partners who helped make this event possible. As we continue to empower women, youth, and children through education and community development initiatives, we invite you to support NWAG's causes through donations. Your contribution will help us sustain our efforts and make a meaningful impact in our community. We are cordially inviting you to join us for our annual June event, Awards Gala. It's coming up this June 28th at the Temple in Atlanta. This special evening will celebrate excellence, honor the outstanding individuals who have really helped our communities, and to raise funds for our initiatives. We invite you to please check out our website, nwag.org, or any events that we have, and also for membership. We're looking for new members to join us in helping us meet our goals. So please, please, please check us out. And of course, we look forward to seeing you both at our June event and in future events. And we continue to look to coming together to build a brighter future. So thank you so much for coming, and we'll catch you at the next NWAG Presents. Thank you all.
Thank you, Dr. Yeti Iziani. Thank you, Dr. George Arnold. We cannot thank you enough. We are really grateful We have Dr. Arnold's information, his full information on the screen at this time. If anyone wants to do a screenshot, you can reach him at this telephone number. Thanks again, everyone, for joining us for another episode of NWAG Presents. Have a good evening. Thank you.
Thank you.
Thank you, Dr.
Thank you, Dr. Arnold.